Welcome back to another episode of the Oncology Brothers podcast. I'm Rahul Gosain here with my brother and co-host, Rohit Gosain. Today, our focus is going to be on Inavolisib that recently got approved for metastatic hormone receptor positive breast cancer based off INAVO120 study. This study was first presented as a late-breaking abstract last year at SABCS 2023, and then on October 10th, 2024, based on its findings, Inavolisib was approved. To unpack the key takeaways from this approval and how does this drug really fit in our current treatment landscape, we're joined by Dr. Komal Jhaveri, a medical oncologist and the senior author on this study from the Memorial Sloan Kettering Cancer Center. Komal, thank you so much for joining us.
Rahul and Rohit, thank you so much for having me today. And delighted to talk to you about Inavolisib and the data that we presented and now that's published as of this month, or this past month, I should say, in the New England Journal. So thank you so much for having me today.
Komal, welcome and congratulations on the study and especially on top of that FDA approval. This metastatic space indeed is getting crowded and which is in fact a good problem to have. Where the current standard of care in metastatic space stands as CDK4/6 inhibitor plus AI in frontline for metastatic hormone receptor positive patients. And after progression here, we start looking for actionable mutations. If one has PIK3CA mutation or alteration, choice becomes capivasertib or alpelisib. Or if ESR1 mutation, then elacestrant, or BRCA mutation, then we're relying on PARP inhibitor. Also, we know we are dealing with something aggressive when the disease in fact progresses within 12 months of AI or shortly after completion. With that background in mind, can you please walk us through the study design of INAVO120?
Absolutely. So INAVO120, it really was born out of the data that we actually initially presented and now is published as well from the phase 1 trial that evaluated this novel PI3K alpha isoform specific PI3K inhibitor Inavolisib. And really, this, the uniqueness in terms of the preclinical data for Inavolisib is that one, it is very, very potent for the alpha isoform compared to the other three isoforms, the beta, delta, and the gamma, which is attractive because we know that that's where the oncogenic driver is, the PIK3CA mutation, which is what we're going after. But also preclinically, it actually causes degradation of the mutant PP110 alpha. And that is what could potentially explain the slight differences in the toxicity profile and how we view the efficacy data and how we were able to actually study a triplet regimen and show that it was safe and tolerable in the phase 1 setting. But then INAVO120, which is the registrational phase 3 that was designed, was really focusing on a group of patients, which was very unique, right? It was not that we were trying to study all patients with PIK3CA mutations. We went after the most, a troublesome patient group in that the most poor prognostic patient group. And how did we identify that group? So we're talking about patients who progressed on or within 12 months of their adjuvant endocrine therapy, for which normally we would have offered fulvestrant with a CDK4/6 inhibitor as a standard of care. Now, these patients were required, obviously, to have a PIK3CA mutation so that we can target it with an alpha-specific PI3K inhibitor. They were required to have measurable disease on this trial. And the way the PIK3CA mutation was detected was that majority of these patients had this alteration detected through cell-free DNA. So this tells you that there is enough disease burden that's spilling in the plasma, which is how we're detecting this PIK3CA. Now, PIK3CA is a clonal or a truncal alteration. You can certainly test it in primary tissue. You can test it in metastatic tissue. You can test it in plasma. And all of that is okay because it's truncal, it's clonal. What's present and driving the biology stays that way throughout the journey. But here we identified majority of our patients that were detected through the plasma, just kind of telling you that these were patients with, a lot of visceral metastases, 50% had liver metastases, and that is what is reflective of this patient population. Now, unique criteria about hemoglobin A1C and fasting glucose also to bear in mind, based on the toxicity profile that we had studied in the phase 1 setting where we had seen, hyperglycemia with this drug like we see with other PI3K inhibitors because it's an on-target effect. It's the inhibition of the wild type as well that we see, which causes this on-target side effect. We had chosen a hemoglobin A1C cutoff of less than 6% and a fasting glucose value of 126 milligrams per deciliter. These patients, 325 of them, were then randomized 1:1 to the triplet regimen of fulvestrant, palbociclib, and Inavolisib, which is administered at 9 milligrams orally daily based on the dose that was identified in the phase 1 that I was talking about, compared to palbociclib, placebo, and fulvestrant for a primary endpoint of progression-free survival by investigator assessment.
Komal, thank you for laying that foundation. The primary endpoint, PFS, secondary endpoint was overall survival benefit. What did the study show? Of course, this study was a positive study that led to the approval of this drug, but can you walk us through the findings and what does this really mean for our patients?
Absolutely. I think that's exactly what is really, really important. So, first of all, I want to say this was a median follow-up of about 21 months. And at that follow-up, we saw a near doubling of progression-free survival by investigator assessment, our primary endpoint, an improvement from 7.3 months in the control arm to 15 months with the addition of inavolisib to fulvestrant and palbociclib. The hazard ratio here is 0.43 and a p-value which was highly statistically significant. Now, if you look at the Kaplan-Meier curves, the Kaplan-Meier curves start separating right from the get-go. Now, many times in ER-positive studies, you'll see that initial drop-off, and then you'll start seeing the curve separating after. But here, you're seeing this benefit predominantly beginning very early on in these patients as well. More importantly, when we did the landmark analyses as well, we also saw that even at a time point that we were looking at around 18 months or 12 months, we were looking at a progression-free rate, which was more than double than the control arm. For instance, the progression-free survival rate in the landmark analyses improved to about 46% compared to 21%. So really something that we saw in this patient population with respect to primary endpoint. Now, the secondary endpoint, we did have a hazard ratio of 0.64, which is very favorable. We did have a p-value of 0.038, but I have to say that that p-value cannot be claiming statistical significance at this time point, at this same median follow-up of 21 months, and we're really eagerly awaiting mature follow-up data for this overall survival as well. But what really caught my eye, even in the Kaplan-Meier curves, of that overall survival data, again, when we look at the landmark analyses at the 6-month time point, so very early on a first-line trial, right? Patients have not had any other therapy but this first therapy. And we saw that 90% were alive in the control arm at 6 months, which means 10% were not. In contrast to 97% that were alive with the addition of inavolisib. So this is really, again, highlighting and underscoring the fact that this was really a poor prognostic group that otherwise does not perform well. And with the addition of inavolisib, we did see this benefit. At ASCO this past year, or this year, I should say, it feels like a long time ago at this point, but at ASCO, we also presented data for PFS2 and time to chemotherapy. And again, we showed that there was benefit with the triplet regimen, even when we look at PFS2 and delay in time to chemotherapy, that was significant as well. So I think now we're really awaiting the mature overall survival data. But again, this is approved, as you pointed out. And I would say really, really highlights the importance of testing PIK3CA mutations first thing when patients have a diagnosis of metastatic, especially if they have recurred on or within 12 months of their adjuvant endocrine therapy. So if you have an endocrine-resistant patient, I think this would be very valuable to consider given this dramatical increase in PFS that we're already seeing, which is so statistically significant.
Thanks for reiterating the important findings here, especially talking about the delayed progression-free survival from PFS2, as well as PFS, and in fact, the overall survival benefit, doubling of PFS in a very high-risk patient population. This is remarkable, especially when you talk about this high-risk population here. And as we can see, it's from the comparator arm, as you mentioned, Komal, these patients usually don't do well if you're just starting them out on just AI plus CDK4/6. Komal, in your practice, when do you get NGS testing, and is liquid biopsy good enough here? I know you mentioned that right at the start of metastatic itself, but on progression, and is liquid biopsy good enough?
Yeah, no, that's a fantastic question and very important one that we actually should discuss. So I'm practicing obviously at Memorial Sloan Kettering Cancer Center, and I have to say we have our in-house NGS assay called MSK Impact. And honestly, we've been doing NGS testing from tumor tissue at the time of metastatic diagnosis for years now. And at that point, I think we had initially started doing it for trial purposes, for understanding the genomic landscape between primary and metastatic disease. So the way we tried to do it was not because we knew that trials like INAVO120 would be approved and the importance will be becoming much more important, but that's how the field has evolved. So if back in the day, we were to think about when should we test the tissue at the very minimum, right? Because obviously in the United States, access is different, but globally the access could be different as well. And one has to bear that in mind. We would say that first line, every patient should get CDK4/6 inhibitor. And at least at the time of progression on a CDK4/6 inhibitor, in the second line setting, we now have approval for LSS strand if they have an ESR1 mutation, if they have a germline mutation in BRCA1 or 2, we have PARP inhibitors. We have 3 drugs available targeting the PI3K-AKT-mTOR pathway. We had approval for everolimus, regardless of any mutation testing. We have approval now for capivasertib as of November 2023 by the US FDA, where we can offer that drug with fulvestrant to patients whose tumors harbor PIK3CA, PTEN, or AKT alterations. We have alpelisib since 2019 for patients who have PI3K mutations. And so we were definitely doing it at least in the second line setting. But the way I have been practicing for a while now, and now I feel like it's becoming more and more evident and important with these data, is that it's very easy to get access to metastatic tissue because you're doing a biopsy anyway to confirm the diagnosis, right? So say if you have a de novo patient, you certainly need a biopsy to prove they have metastatic disease. If you have a patient who was already treated and now has suspicion for recurrence, you are going to do a biopsy and you will need to test the tissue. So because you have that tissue, and if you already know that this patient recurred on or within 12 months of adjuvant endocrine therapy, really, really important to remind yourself to do the NGS because PIK3 mutations are clonal or truncal. So you don't really have to wait for progression on a CDK4/6 inhibitor to know what happened to the tumor for a PIK3CA. Even if you were to test primary tissue, you would still be able to offer the same therapy to these patients with a new diagnosis where you couldn't test the metastatic tissue, but you already had the data available from primary tissue. So in my practice, newly diagnosed patients, everybody gets tissue. During the INAVO120 study, when I was enrolling patients to the clinical trial, I would also send out a ctDNA test because the turnaround time for ctDNA was about 7 to 8 days with Guardant 360. Right now, the companion diagnostic that has been approved with the INAVO120 data is the Foundation Medicine assay. So certainly you have options available. You have CLIA certified assays that can help identify these alterations. I do tissue at the time of diagnosis. I do cell-free DNA usually serially, but definitely at the time of progression of CDK4/6 inhibitor. And I would certainly consider repeating biopsies during the metastatic journey for a patient for the right setting. Very limited duration of treatment response on a therapy, or if I were to look for HER2-low disease to offer them trastuzumab deruxtecan, amongst other reasons to do this. But at least at the time of diagnosis and cell-free DNA at the time of progression.
Absolutely. And as a community oncologist, we're doing this more and more already, be it in lung cancer, of course, and breast cancer. And the reason to even consider serially something that we don't do for other diseases is to look for ongoing mutations like ESR1 and so forth, because you do have potential options. Komal, you touched on this a little. Capivasertib, which is also approved here in second line for AKT, PTEN, and PIK3CA mutation. Is inavolisib active for AKT and PTEN mutation as well?
So fantastic question again. And the answer is no. This is an alpha isoform specific PI3K inhibitor. And one of the potential mechanisms of resistance to PI3K inhibitors is actually development of or acquired PTEN alterations. And that's where we would think that AKT inhibitors potentially could play a role. So right now, you should only be offering inavolisib or alpelisib to patients with PIK3CA mutations only. In contrast, capivasertib could be offered to patients with PIK3CA mutation, with AKT mutation, or a PTEN mutation. So that's the difference right now in practice. We don't have data for capivasertib in a triplet regimen in the first line setting yet, but the trial of Capitella 292 is currently ongoing, and hopefully we'll have an answer to that question for that triplet as well in the future.
Thanks for covering that, Komal. Just to push you a little bit on the NGS theme again here, what if we have ESR and PIK3CA co-mutation, though we have a utility with elacestrant, which especially for a slow progressing disease. However, if we know that these patients are going to be aggressive, if they are progressing within that 12-month frame of initiating AI, would you be committing these patients to triplet regimen based on INAVO120?
Yes, I would. So the short answer is yes, I would. If you recall, when we looked at all the data and the ctDNA analyses from the CDK4/6 inhibitor trials, just as a doublet with endocrine therapy and CDK4/6 inhibitors, we did see that there was responses that you would see, especially if you were thinking about ESR1 and you would offer them fulvestrant as well as a combination, right? Upfront, ESR1 mutation rates are lower. That increases with second or third line therapy. So if you were to look at the Mona Lisa 2 data, which evaluated ribociclib with fulvestrant, and that looked at baseline ctDNA ESR1 mutations, the prevalence there was 4%. Now, certainly we anticipate that maybe perhaps with extended adjuvant endocrine therapy, this rate might be higher potentially in patients, and we need to learn a little bit more about that. But when we're talking about second or third line ESR1 mutation prevalence, we're talking about 40 to 50%. Right. So very different there. Here, the patients are certainly getting fulvestrant, which would cover at least some of this ESR1 mutations already. There is some data to suggest that maybe ESR1 Y537S is not the great mutation that fulvestrant can have activity for, but for the others, it would. And again, the prevalence is going to be lower, much lower in the first line setting to have a co-occurring alteration for which we would worry about, because we're still going to give them fulvestrant, we're still going to give them a CDK4/6 inhibitor, and we're going to still give them a PI3K inhibitor for the PIK3 alteration. And one more point to make to that was, even with the PARA-1 trial, which really looked at emerging ESR1 mutations, we followed patients who started on an AI with a CDK4/6. And if they develop a ESR1 mutation but do not have radiological progression, we randomize them to continuing the same treatment or switching them to fulvestrant and a CDK4/6 and show that that is beneficial. So again, that supports the idea that fulvestrant might be appropriate, and this prevalence rate is going to be much lower in the first line. So hopefully that answers your question.
Yeah, no, absolutely. Rohit, and I think you're bringing this up because elacestrant is well tolerated, and we all get nervous around tolerability and how to manage side effects of anything that is newly approved. So Komal, I think this is a good segue if we can take next few minutes to focus on the side effect profile and some clinical pearls that you can offer on how to manage some of the key toxicities. As you've mentioned, neutropenia, again, we're using CDK4/6 inhibitors here, hyperglycemia, GI side effects are more of a class effect that we tend to see with this. Any thoughts around this?
Yeah, no, it's a fantastic question. Certainly efficacy is very important, but safety is equally important just to make sure that patients can really adhere to a therapy that we intend to give them to improve their outcomes. And so, yes, I think the short answer is there were no new signals of safety profile than what we're already aware of. If we think about the individual contribution or the individual side effect profile for the drugs, the trial showed that the same side effects that we would have expected from palbociclib or from fulvestrant and with the PI3K inhibitor is what we saw with the triplet. Again, very important to appreciate here that while the preclinical data really supports the synergy of these three drugs and we've been able to show efficacy here, this was not a new thing. We had attempted that with other drugs as well. We had attempted the 3 triplet regimen even with alpelisib and ribociclib and endocrine therapy, but that was not safe and tolerable. That perhaps speaks to the preclinical differences that I was referring to with inavolisib. But certainly we see hyperglycemia rates. We did see about 58% of the patients with all grade hyperglycemia. Grade 3 or 4 hyperglycemia rates were about 5.6%. We did see stomatitis with this the triplet combination as well. It was 51% all grade stomatitis. We did see some grade 3 stomatitis as well. Not all patients got primary prophylaxis with the dexamethasone mouthwash, which is what we normally now do with drugs like everolimus and should do with this. Also in the control arm, in the palbociclib fulvestrant arm, approximately 27% of the patients had stomatitis as well. So certainly we do see stomatitis. I think very important for us to remember to use dexamethasone mouthwash when we start utilizing this drug in clinic. We did see some diarrhea rates as well. All grade diarrhea and some low grade 3 diarrhea of about 3 to 4% or up to 5% if I recall the right numbers for diarrhea. And rash, we did see low-grade rash, but there were no grade 3 rash. Now, this is slightly different from what we've seen with, say, capivasertib, where the grade 3 rash was 12%, or with alpelisib, where we also saw grade 3 rash and discontinuations related to rash as well. So we don't see grade 3 rash with this drug, again, slightly different. So while all of these side effects, stomatitis, hyperglycemia, diarrhea, rash, are a class effect, we do see that there are some differences between all these agents that target these pathway agents, right? Everolimus causes predominantly mouth sores or the stomatitis. When you look at capivasertib, we worry about diarrhea and rash. When we look at alpelisib, we think about hyperglycemia, diarrhea, and rash. With inavolisib, I would say it's hyperglycemia. With the triplet, you should keep an eye on the stomatitis. And there is some low-grade rash, but no grade 3 rash that was seen.
Thanks for covering that, Komal. And as you stated, this is a class effect. Komal, before we wrap up, any ongoing study with Inavo, particularly with Abema or Ribo? Because, of course, with, as we know, the CDK4/6 inhibitors, where Abema and Ribo has better survival data when compared to Palbo.
Yeah, fantastic question, Rohit. I'll just add one more thing to remind ourselves that the discontinuation rates with this triplet regimen were rather low. So it was very reassuring to see there was about 6% for the triplet, which is definitely different than what we've seen as discontinuation rates with the other agents in other trials as well. And with other trials that are currently ongoing, the Morpheus phase 1 study is currently evaluating the exact question you were asking: inavolisib in combination with endocrine therapy and ribociclib, and inavolisib in combination with endocrine therapy and abemaciclib to generate that safety and tolerability data as well. But currently, the approval for INAVO120 and this first-line regimen is with palbociclib. And I do think that given that it was a randomized study and given that it's a 3-drug regimen, I'm not so sure, unless we know from a head-to-head study, what that individual contribution for a different CDK4/6 inhibitor in this triplet would look like. But I think it'll be very, very important to generate the data as we are, given that our control arm certainly has evolved since this trial was designed. Another study that I should point out is INAVO121, which is actually in the second-line setting, a head-to-head trial comparing Inavo fulvestrant with alpelisib fulvestrant. So we'll have some second-line data as well to be able to tell, are there truly any differences between the two drugs, and should we be thinking about one over the other with respect to efficacy and safety?
Absolutely. Komal, thank you so much for sharing your thoughts and walking us through INAVO120, which again has led to the approval of inavolisib in selective, locally advanced or metastatic hormone receptor positive breast cancer. For our listeners, let's go over quick recaps from today's discussion.
Today, with Dr. Jhaveri, we had a chance to focus on INAVO120 study that has led to the approval of inavolisib with fulvestrant and palbociclib in endocrine-resistant disease with PIK3CA mutated, hormone receptor positive, HER2 negative, locally advanced or metastatic breast cancer following recurrence on or after completion of adjuvant endocrine therapy.
Inavolisib resulted in significant improvement in PFS as we saw median progression-free survival of 15 months with inavolisib versus 7.3 months in a control arm. It is important to keep side effects including neutropenia, hyperglycemia, and GI toxicities in mind while using inavolisib. Given its approval, this option should now be considered in our selected hormone receptor positive breast cancer patients. Thanks for joining us. We also look forward to seeing you in person at SABCS 2024 to discuss this quickly changing treatment landscape. We are the Oncology Brothers.